أبناء وبنات الدارسين للجراحة العامة. This is Dr. Baki, Professor of General Surgery from Egypt. We are going to continue revision of breast through MCQ question, and this video is number 7. 57-year-old woman undergoes imaging-guided biopsy of a 1.5 centimeter speculated centrally dense mass. Pathologic review shows benign breast parenchyma. Which of the following is the most appropriate recommendation at this point? So long he is describing speculated mass, this means suspicious mass. Although it is suspicious, but the core needle biopsy came benign breast parenchyma. Does this going to worry you, or what are you going to do? Routine screening mammography in 1 year, additional imaging with contrast enhanced MRI, short-term follow-up in 4 to 6 months, wire localized excisional biopsy, or tamoxifen. The principle is, so long there is suspicious mass during imaging, don't rely on just core needle biopsy if the result came benign, because there may be sampling error. You should excise the whole speculated area and subject it to histopathological stained slide. And this will be done by wire localized excisional biopsy. Go for wire localized excisional biopsy. يعني لازم نشيل الجزء ده كله ال 1.5 سنتيمتر، بنعمل له localization ب hooked wire, and we send the lady for the operating room. The whole hooked wire with the surrounding area will be removed and subjected to histopathological examination, and this will be more accurate than just guided biopsy, okay, because this mass is suspicious. Go for D. 47-year-old woman undergoes modified radical mastectomy for T2N2 infiltrating ductal carcinoma. She arrives at her first post-operative visit complaining of hypocesia of the upper posteromedial aspect of the ipsilateral arm. What might explain this finding? All of you know that many nerves are present in the axilla and you have to preserve. One of these nerves is second intercostal brachial nerve, a nerve going through the axilla to receive sensation from the posteromedial aspect of the arm. This nerve is going through the lymph nodes in the axilla. During axillary dissection, you might cut this nerve, and this will cause hypocesia of the posteromedial aspect of the ipsilateral arm. It will take some time and then disappear. So, is this caused by lymphatic fibrosis, medial pectoral pedicle injury, second intercostal brachial cutaneous nerve injury, axillary vein thrombosis, thoracodorsal pedicle injury? Go for C, second intercostal brachial nerve. This is the axillary vein, and this is your upper limit of dissection during axillary dissection. And this nerve is nerve to serratus anterior, or lateral, what is called lateral thoracic nerve. And this bundle is thoracodorsal bundle, blood vessels and the nerve going to latissimus dorsi. Okay. So in this question, go for second intercostal brachial cutaneous nerve injury. What is the incidence of lymphedema after axillary node dissection level 1 and 2? 5, 10, 20, 40, or 50%? Go for 20%. 20% of ladies after axillary dissection may get such edema because of impaired lymphatic drainage of the arm, because you removed lymph nodes and some lymphatics from this axilla. This incidence is lower nowadays because we start with sentinel lymph node biopsy. If sentinel lymph node is negative for malignant cells, we abandon axillary dissection, and this action will decrease lymphedema postoperative. Of course, lymphedema of the arm can occur in carcinoma of the breast because of malignant cells invading axillary lymph nodes and the lymphatics of the axilla. And this incidence will increase if you follow mastectomy, if you follow this axillary dissection by postoperative irradiation. This incidence will go up, okay? But it goes around 20% if it is just after axillary node dissection, okay? You have to advise this lady postoperatively not to draw any blood from this arm or measure blood pressure from this arm, because this will occlude more lymphatics from this arm and this will increase lymphedema. She has to treat any little cellulitis, because any cellulitis will occlude more lymphatics from this arm. And she has to do some exercises and arm elevation and sometimes some sort of crepe bandage to decrease edema of the arm, okay? She has to avoid any source of infection or scratches to her hand. Radiation delivered to the breast after right lumpectomy and sentinel lymph node biopsy for a 1.2 centimeter node negative infiltrating ductal carcinoma is likely to be associated with which of the following? لما بندي post-operative irradiation to the remaining breast after breast conserving surgery, what is our aim? What is our goal? Is it to decrease risk for systemic recurrence? No, because chemotherapy is the one who is going to decrease risk of systemic recurrence. This post-lumpectomy breast radiotherapy can be used in lieu of chemotherapy in early stage breast cancer? No, because chemotherapy is used to control systemic metastasis and radiotherapy is used to decrease locoregional recurrence. Chemotherapy used to prevent systemic recurrence or systemic metastasis. Radiation therapy is used to control locoregional recurrence, okay? We give postoperative radiation and this will increase the risk for lymphoma. This is not true. We give postoperative radiation to decrease risk for local recurrence. Yes, this is a correct statement to go for D. Postoperative radiation can cause cardiac toxicity very, very rarely. This is not common side effects of postoperative radiation nowadays, and you can shield the heart against radiation, okay? So in this question, go for D. For which patient described below is an aromatase inhibitor such as anastrozole considered to be useful? علشان تعرف القصة طبعا احنا بندي something to block estrogen receptors to decrease growth of tumor, to prevent recurrence, and the most famous is tamoxifen. Tamoxifen can be given to premenopausal and postmenopausal lady. But for postmenopausal lady, steroid hormones in her body is going to convert to estrogen in peripheral fat. You have to give something to prevent this conversion. In postmenopausal lady, the only source of estrogen not from her ovary, but from peripheral conversion of steroid to estrogen in peripheral fat. You have to prevent this by aromatase inhibitor, anastrozole. So The principle is we give this drug to postmenopausal lady who is ER positive. So you have to search here for postmenopausal lady who are ER positive. 57-year-old woman with T1 and 0 ER positive breast cancer. Yes, this lady is suitable for aromatase inhibitor. She is postmenopausal and she is ER positive. 35-year with LCIS, it is not suitable because this is premenopausal. 65-year-old with T2 and 1 ER negative, this is not suitable because she is ER negative. 42-year with DCIS, not suitable for aromatase inhibitor, she is premenopausal. 45-year-old woman who is non-carrier of the BRCA mutation. A lady who is carrier of BRCA mutation and is in need for chemoprophylaxis against future development of breast cancer is going to receive tamoxifen. Aromatase inhibitor up till now is not proved as a chemoprophylaxis, but tamoxifen is proved. So in this question, go for A. What additional treatment should a 42-year-old patient with a 2 cm focus of ER positive DCIS transected at the margin by lumpectomy receive? This scenario about a lady doing lumpectomy or breast conserving surgery, but the margin of the field is positive for malignant cells. The lumpectomy specimen, there is malignant cells at the margin. This means that the surgeon transected the edge. He is not taking a safety margin. He is not taking the 1 centimeter safety margin. So what are you going to do? Are you going to advise for radiation therapy alone, or tamoxifen alone, or surgical re-excision alone, or surgical re-excision and tamoxifen alone, or surgical re-excision radiation therapy and tamoxifen? Go for E. Why? You have to go again and re-excise the surgical field to guarantee free margin free of malignant cells. And of course, for the remaining breast, she should receive radiation therapy because this is a very important component of breast conserving surgery. And she should receive tamoxifen because it is ER positive. So go for E. An ultrasound image of a patient's breast reveal a 2 cm simple cyst. Aspiration yields clear straw-colored fluid. This is straw-colored fluid. And there is complete resolution on post-procedure ultrasound imaging. What should the clinician next step be? A lady came to you with a simple cyst. You aspirate the cyst. You got this kind of fluid, straw-colored fluid, and there is no more cyst, there is no masses proved by post-procedure ultrasound. What is your next step? Order repeat ultrasound imaging in 3 months. Have the fluid sent to the laboratory for hemocal testing, cytological studies, and assessment for tumor markers. Perform wire localized excision of the cavity, prescribe antibiotics for the patient, advise the patient to continue with routine clinical breast examination and mammogram. Go for E. This is a very frequent scenario in your clinic. A lady came with a cyst, you aspirate the cyst, and the problem is over. Everything is resolved. You are going to advise the lady to continue with routine clinical breast examination and mammogram. Only if the cyst recur for the second time and the lady is postmenopausal, you might excise the cyst for histopathological examination. And if the aspirate is bloody, you have to send it for cytological examination. And if there is a remaining mass after aspiration, you have to excise the cyst to rule out malignancy. Only on those situation. But in this scenario, it is enough to advise the patient to continue with routine clinical breast examination and mammograms. No need to send this fluid to the lab if this is the first aspirate. And in some textbooks, is telling even if the second aspirate like this and the cyst recur and you have to aspirate again and there is no mass after this aspiration, even with the second aspirate, you don't have to send it for the lab. And they are telling if it recur for the third time, you have to send. But some books is telling if it is recurring for the second time and the lady postmenopausal, you have to remove the cyst. Excise the cyst for histopathological examination. The long thoracic nerve. The long thoracic nerve. This is the axilla. After axillary clearance, you will see one nerve lying over the serratus anterior muscle. Its name is long thoracic nerve. Sometimes we call it nerve to serratus anterior. Sometimes it is called external respiratory nerve of Bell. Okay? It supplies serratus anterior muscle. Serratus anterior muscle arising from the upper 8 or 9 ribs and inserted in the medial border of the scapula. Its function is to stabilize the scapula to the chest. It fixes the scapula to the chest during shoulder movement, and this is easy, make shoulder movement easy. Okay? This is the rule of long thoracic nerve. Another important nerve, you have to keep it safe and secure during axillary dissection, is thoracodorsal nerve going to latissimus dorsi. Latissimus dorsi is going to adduct and internally rotate your arm during its function. Okay? If this serratus anterior nerve is injured, the scapula is no more stabilized to the chest wall. And this is the clinical test you are going to do. You ask the patient to push the wall, and you will find his scapula winged like this because it is no more stabilized to his chest wall. Okay? Let us see what is the correct statement. The long thoracic nerve innervates the latissimus dorsi muscle. This is incorrect because what innervates latissimus dorsi is thoracodorsal nerve or nerve to latissimus dorsi. Long thoracic nerve or nerve to serratus anterior arises from the posterior cord of the brachial plexus. This is wrong. It arises from the 5th, 6th, and 7th cervical nerve. Okay? What arises from the posterior cord of brachial plexus is thoracodorsal nerve. Okay? The nerve to serratus is located deep to the axillary artery and the vein and then travels superficial to the deep fascia of the serratus anterior muscle. This is correct statement. This statement is correct. It comes from behind axillary vein and artery and then run over the serratus anterior on the medial wall of the axilla. This nerve you will see on the medial wall of the axilla during axillary dissection. The thoracodorsal nerve you will see in the posterior wall of the axilla. So this is correct statement. These two will be incorrect. It is also called the internal respiratory nerve of Bell. No, it is called external respiratory nerve of Bell. It has minimal significant sequelae if damaged during axillary dissection. Wrong. It has significant morbidity if damaged because it will affect shoulder movement significantly. But this latissimus dorsi, if you injure its nerve, after a while the patient is going to accommodate or cope with its dysfunction. But for serratus anterior, it has a significant sequelae. You cannot tell minimal at all. Okay? So in this scenario, go for C. All of the following are important features of patient's initial assessment and are known risk factor for breast cancer except family history of breast cancer. Yes, it is known risk factor. Age of menarche. Yes, the younger the lady at menarche, the higher the risk factor. History of atypical hyperplasia. Yes, atypical hyperplasia increases the chances of developing breast cancer 4 or 5 times. Radiation exposure as a teenager. Yes. History of ductal adenosis. No. This is the exception. Why? Ductal adenosis means hyperplasia and hypertrophy of the lobules of the breast in fibrocystic change of the breast. It does not increase the chance of developing breast cancer. This is the exception. Okay? 35-year-old woman arrives at your office stating that she has a 1-month history of palpable right breast lump. On physical examination, you are able to palpate 1 centimeter solid mobile firm nodule at 2 o'clock position. Your diagnostic evaluation for this newly found breast mass in a 35-year-old lady will be mammogram, ultrasound, core needle biopsy, short-term follow-up, all of the above. Go for all of the above. This lady age allow you to do both mammogram and ultrasound. And you have to complete triple assessment by doing core needle biopsy. And even if the core needle biopsy came to you benign parenchyma, you have to do short-term follow-up for this lady. Suppose this core needle biopsy not came benign, but not in accordance with the imaging or the clinical history and examination of the lady. At this time, you have to do surgical excisional biopsy. You have to remove the whole lump, not only sampling it. Okay? If the mass is solid, a core biopsy should be performed regardless of appearance on imaging. You have to complete the triple assessment, which is history, physical examination, imaging, and core needle biopsy. Okay? If you find any atypia or abnormality in this core needle biopsy, this should warrant or should be followed by surgical excision. Okay? So in this scenario, all of the above will be done. Thank you so much for watching this video. This is Dr. Baki, Professor of General Surgery from Egypt. Now kindly like, share, and subscribe.